The axillary block is a type of regional anesthesia indicated in patients undergoing surgery on the forearm, elbow, or hand. This includes orthopedic surgery, wound debridement, ligament repair, and vascular access surgery. Assemble the required equipment before beginning the procedure. This includes two 30 milliliter syringes connected by a three-way stopcock, 60 milliliters of the local anesthetic of your choice, IV tubing, a 22-gauge 1.5-inch needle, a 5 milliliter syringe with 25-gauge needle, and 1% lidocaine. You will also need sterile surgical towels, sterile prep solution and sponges, a marking pen, and gauze. If the block is to be performed by nerve stimulation, you will need, in addition, a 1.5-inch 23-gauge stimulating needle and a nerve stimulator with electrode. Lay the patient in supine position and abduct the arm at a 90-degree angle. Flex the elbow and prop the forearm on a pillow. With the patient's arm flexed at a 90-degree angle, you can better appreciate the outline of the biceps and coracobrachialis muscles. Palpate the axillary artery. Identify and mark the anatomical landmarks. Here we have labeled the biceps brachii and coracobrachialis muscles. Inferior to the muscles, we have labeled the axillary artery. Prep the arm with sterile solution, beginning at the axilla and proceeding outward. Repeat the prep 3 times and allow the solution to dry before needle insertion. Using sterile surgical towels or a fenestrated drape, cover the patient's upper arm and shoulder. If you are planning to use a nerve stimulator to locate the axillary nerve, leave the forearm and wrist uncovered to permit visualization of the muscle twitches generated by the nerve stimulator. Palpate the axillary artery with your palm facing away from the patient's body. This allows you to feel the artery without obstructing your view, and also enables you to stabilize the artery's position between your fingers. Introduce the 25-gauge needle into the skin between your 2 fingers. Inject 2 milliliters of 1% lidocaine. Before inserting the 22-gauge needle, ask your assistant to flush the needle to remove air from the system. Insert the 22-gauge 1.5-inch needle into the wheel raised by the local anesthetic. Direct the needle tip toward the axillary pulse. Ask your assistant to gently aspirate the syringe as you advance the needle. When the needle tip enters the axillary artery, aspiration will cause blood to flow into the IV tubing. Continue to advance the needle through the vessel. Blood will no longer flow freely into the tubing when the needle tip has passed into the tissue behind the artery. Viewing the internal structures of the upper arm in a quadrant pattern, you can appreciate that after the needle transverses the axillary artery, the tip is located close to the radial nerve. When blood no longer flows into the tubing, flush the needle. Aspirate the syringe again to confirm that the tip is no longer in the vessel. Negative aspiration substantiates the extravascular location of the needle tip. Inject 25 milliliters of local anesthetic, aspirating every 5 milliliters to ensure that the medication is not introduced into the intravascular space. The anesthetic spreads into the distal axilla, blocking the radial nerve. After injection of anesthetic, withdraw the needle, aspirating the syringe. Blood will again fill the tubing when the needle tip passes through the vessel as it is withdrawn. Flush the needle and aspirate a second time. If blood continues to fill the tubing, the tip is still located in the vessel, and the needle needs to be pulled back 1 to 2 millimeters. Continue to aspirate the syringe and flush the needle until dark blood no longer fills the tubing. If you flush the tubing and aspirate translucent pink blood, it is not blood from within the vessel. This blood is aspirated as a result of trauma to the nerve sheath, indicating that the needle appropriately entered the nerve sheath while delivering anesthetic. Inject the remaining 5 milliliters of anesthetic into the space superficial to the axillary artery, thus blocking the median and ulnar nerve. Remove the needle. Compress the axillary artery for 5 minutes to prevent the formation of a hematoma. Remember that the patient is losing motor control of the arm and that you will need to carefully position the arm to maintain the patient's safety and comfort. To foster the block, adduct the patient's arm and rest the hand on the chest. This movement will rotate the head of the humerus and facilitate proximal spread of the anesthetic. Place your fingers on the axillary pulse. Using the 22-gauge needle, inject 2 milliliters of 1% lidocaine to raise a cutaneous wheal 1 centimeter superior to the pulse. Repeat this step to create a second cutaneous wheal 1 centimeter inferior to the pulse. Hold the stimulating needle perpendicular to the skin and insert it through the cutaneous wheal into the subcutaneous tissue. Turn the nerve stimulator on and set the current to 1 milliamp. Advance the needle toward the median nerve, which is located superior to the axillary artery. You may perceive a popping sensation as the needle tip traverses the superficial brachial fascia. Advance the needle until the median nerve is stimulated, causing wrist flexion and forearm pronation. You should also see flexion of the thumb, index finger, and middle finger. Aspirate the syringe to ensure that the needle tip is not located in a vascular structure. Inject 25 milliliters of local anesthetic, aspirating the syringe after every 5 milliliter dose. Remove the needle from the arm. Reinsert the needle inferior to the axillary artery and superior to the triceps muscle. Turn the nerve stimulator on and set the current to 1.5 milliamps. Advance the needle slowly. The ulnar nerve is superficial to the artery. When the stimulating needle is correctly located, you will see flexion of the 4th and 5th digits and adduction of the thumb. Raise the hub of the needle 15 degrees, dropping the tip inside the arm. Advance the needle slowly toward the radial nerve, looking for muscle stimulation. You will see both wrist and finger extension upon activation of the radial nerve. Decrease the nerve stimulator to maintain muscle stimulation. Aspirate the syringe and inject 25 milliliters of anesthetic around the radial nerve. With each injection, ask the patient about symptoms that would indicate intravascular injection, including ringing in the ears or metallic taste in the mouth. Remove the stimulating needle. Palpate the axillary artery. Insert the 25-gauge needle into the skin inferior to the artery at the level of the pectoralis major muscle. Aspirate the syringe and then, in a ring technique, inject 5 milliliters of anesthetic as you withdraw the needle. The intercostobrachial nerve and medial brachial cutaneous nerve are anesthetized by the anesthetic, preventing tourniquet-associated pain. To block the superior segment of the same nerves, bend the needle at a 90-degree angle and insert it through the skin superior to the axillary artery. Advance the needle toward the deltoid prominence. Again, aspirate the syringe. Inject 5 milliliters of local anesthetic into the subcutaneous tissue as you withdraw the needle. Reinsert the needle and direct it at a 35-degree angle lateral to the original line of insertion. Aspirate the syringe and inject 5 milliliters of anesthetic as you withdraw the needle. Finally, locate the coracobrachialis muscle. It is inferior to the biceps and superior to the axillary artery. Squeeze the muscle between your fingers and insert the needle into the coracobrachialis muscle. Inject 5 milliliters of local anesthetic in a fan technique. The anesthetic spreads in the tissue to block the musculocutaneous nerve. Position the arm to maintain the patient's safety and comfort. Remember to foster the block, adduct the patient's arm, and rest the hand on the chest. Depending on the medication used, the block may not take complete effect for up to 30 minutes. Surgical incision should be delayed until the medication time of onset has passed.